Hey, go to www.howardfarran.com and get a copy of my new book, Uncomplicate Business. I went through every monthly column I had written from 1994 to 2015, and I looked at those columns and realized that in business, you only manage three things: people, time, and money. So I stripped out all the dental and wrote a book that could take any business to the next level. I don't care if you're a dairy farmer, own a restaurant, you're a plumber. This book is for you. Pre-order my book now. Get your copy at howardfarran.com. It is a supreme honor today to be here with Dr. Pikos we're both speaking at the 11th annual Megagen Implant Symposium in downtown New York City at the Grand Hyatt, and I was lucky enough to bring a camera into the green room before we go on stage to speak over the next 2 days. And you're a legend and an idol and a role model to me and so many. You're one of the only oral surgeons I've ever heard of who doesn't even pull wisdom teeth. I mean, you just practice limited to implantology for 32 years. You have a board certification and diplomat in everything I've ever heard of and more. You have a teaching institute that has people in there learning how to place implants and bone graft from countries and of every continent from around the world. You're just a legend. So first of all, it's just an honor that you would take the time to do a podcast with me. So my opening question to you is, you've been doing this 32 years. I've been doing it 28 years. What's changed with dental implants from when you started placing your first one 32 years ago to today? And how has that changed over the years?
Howard, again, first things first, I appreciate the ability to share some time with you. I've known about you for quite a few years, and first time I get to actually meet you and give you credit for what you have accomplished with Dental Town. As an oral maxillofacial surgeon, as you mentioned, I've had the luxury of limiting my work exclusively to implant surgical-based reconstruction for the last 22 years of my practice. The first 10 years I placed implants and did grafting, etc., but also did pretty much the full scope of my specialty of oral maxillofacial surgery. Being able to limit in one arena has afforded me the opportunity as a clinician, first and foremost, as I do practice still 4 days a week, has afforded me the opportunity to do quite a bit of work day to day, and thereby I can accumulate a fairly significant caseload with regard to the different bone grafting, soft tissue grafting procedures I do, et cetera, et cetera. And I say that only because to more or less qualify the educational arm of what I'm about as well, which for the past 25 years, having the Pikos Institute with some 3,000 alumni from all 50 states, 32 countries, has been a real honor for me, a real blessing to have the, again, luxury, if you will, of having a clinical arm and an educational arm to what I'm all about. And I've enjoyed it. I'm very passionate about what I do. Now, that said, your specific question with regard to changes over the past 32 years, some significant changes for sure. So many. Just briefly, what comes to mind immediately would be basic implant design over time. Different types of designs with regard to the thread design of the implant, to allow for primary stability, for example, to allow for immediate load, which is a concept that wasn't even around for so many years early on. So that's a significant one. And what will continue to evolve will be further designs of implant surfaces, or actually configurations, as well as surface configurations. Nano technology will be playing, I think, a bigger role in the implant design element. The prosthetic components have been changing and evolving very nicely to allow for a very wonderful aesthetic result for the aesthetic zone type cases. And certainly impact of three-dimensional radiography has been phenomenal. I embraced that about 10 years ago roughly, and the cone beam CT element of what we do is huge. Taking a two-dimensional radiograph, comparing to a three-dimensional It's literally night and day. And if that technology were taken away from me personally, I would retire for sure, because the impact of it is just profound. Being able to visualize everything we do beforehand, to virtually plan our cases, to see, most importantly, just from the cone beam itself and the software built into these respective units that are sold, how we can assess the anatomy, existing anatomy, pathology, etc. Having a maxilla, a mandible in the palm of your hand before you even see your patient is just absolutely outstanding, and the impact to be able to treatment plan and with precision, et cetera, et cetera. So those are just a few of the main things that come to mind with regard to changes. No question that we'll be seeing more changes from a biology perspective, from a growth factor perspective. I will tell you that there are a lot of changes within the biologics realm of implant dentistry, such that we're able to have some growth factors to work with, and specifically some recombinant ones, i.e. BMP, bone morphogenetic protein, that allows us to grow bone de novo. So the trend of not having to take autogenous bone for our bone augmentation procedures is there loud and clear, such that we're able to utilize less and less autogenous bone, more growth factors, etc. So we're able to be less invasive in general with all of our work, both hard tissue and soft tissue grafting procedures and implant placement for our patients.
So when we got out of school, the big thing was coating the implants with HA. Remember all the implants 30 years ago were coated, and then that coating started to come off. So is coated implants...
Well, specifically, HA had...
Do you remember what we were talking about, where they were
absolutely
showing it up with macrophages and like kneecaps and other parts of the body?
Unfortunately, not all the biology taken from, say, orthopedic circles can be applied with equal success to the mouth. And that really is the problem, because in orthopedics, we're looking at more of a closed system, the joints, etc. Whereas in the mouth, we have a communication element that is there, unfortunately, and the mouth having the bacterial content that we typically have, implants certainly are vulnerable, as are teeth, to problems, specifically infection and bone loss, and therefore implant compromise and ultimate failure. But bottom line here is that the surface technologies have changed, and whereas HA coating had been quite a popular thing to do, so to speak, in the 80s and into the 90s, what was found, and by the way, I placed quite a few of HA-coated implants in my time.
So did I.
and not all of them, of course, were so problematic, but unfortunately those that were problematic in a big way because of the wicking effect and of contamination at the surface, and therefore compromising bone loss, etc. But today, the nanotechnologies, again, what is available to us is a whole different level of technology that really affords the implant surface to be even better prepared to allow for bone to grow to it with that protein layer that interfaces regardless. And in a nutshell, that's the big push anymore, is to allow for the biology to be changed in such a way that, again, primary stability, primary immediate loading of our implants, that's really where things are at now, where we're able to, in one day, literally extract a tooth, place an implant, put a provisional, not just for a single tooth, but certainly for a full arch of reconstruction.
Okay, but back in the day, they when we were in school, they taught us that there's 4 types of bone. The mandibular anterior, that is just pine wood. You could probably hammer a nail in there and it'd work. Posterior mandible got a lot softer, maybe balsa wood. The maxillary anterior is kind of styrofoam, and the posterior maxilla, there was just nothing there. So when you're talking about immediate loading, are you talking about immediate loading in all 4 different areas of the jaw, or are you talking about just like certain places?
Well, certainly Carl Misch was able to identify very nicely for all of us a very good set of analogy, if you will, in terms of, as you mentioned, type 1 through 4, even a type 5 quality bone identified. and being able to give us the analogy of, yes, type 1.
Go through those five types.
Type 1 basically being like an oak or maple, very dense, extremely dense bone, very minimal vascularity. Lends itself well to primary stability, yes, but care has to be taken with regard to preparation for the implant. A type 2 quality bone would be more of the spruce or pine kind of feel as one drills into that bone. It's a very common bone. Type 2 quality we'll see in the anterior mandible, along with type 1 there. We'll see type 2 sometimes posterior mandible and even premaxilla occasionally. Type 3 is more of the balsa wood that you refer to as feel. That's posterior mandible maxilla typically. And then type 4 would be the styrofoam, very, very soft trabecular bone. So the gradations from type 1 to type 4 really go from a primarily cortical bone with a dense marrow all the way to the type 4 or even type 5, which is pretty much trabecular bone, a very mushy type, no structural integrity to speak of. Now that said,
you said 5 types.
Yeah, and the 5th type is really one that's just a beyond the marrow point, where even there's a degree of how soft is that marrow, so to speak. And that's what's been identified more recently as a type 5, as Carl has talked about. So now that said, when we talk about primary stability, the concept really is one now taken really from the Brandemark days, where basilar bone was talked about. If you may recall, the buzz was back in the day, in the 80s especially, we're trying to engage the cortical plates was a big deal. Well, as we found out, that wasn't so important for typical submerged implant cases, which back in the day, 80s and 90s, early 90s especially, I would place the implants, bury them, and then uncover them, almost like, planting a seed and watching it grow into a little sapling, etc. Well, of course, as we know, the last 15 or more years, we can place these implants and load them immediately. Now, that is predicated on the implant being primarily stable, meaning basilar bone is huge. Once we're able to engage basilar bone, then, in fact, we can have insertion torques of 30, 35 Newton centimeters and straight up to 90 and even 100, which is a tremendous primary stability element. And that's really at the heart of what we're able to do today with our immediate load cases, from single tooth to full arch. But part 2 of that is splinting. When we get primary stability with our full arch cases, the key to success there too is to connect these implant bodies as well, making, in essence, a rigid unit that then allows the body biologically to allow for integration to occur over time. But in the meantime, the prosthesis is in the mouth and the patient is functioning. Soft food, typically, soft diet, but very predictable, very successful.
So this is kind of the backbone of, you hear a lot of the all-on-4, where people are placing 4
Yes.
and trying to go to meet. So you're saying that when you place 3, 4, 6, 8 implants, but connect them together out of the gate,
Correct.
the physics of that allows you to immediately
Yes,
load
and
them.
some great science is available that really validates that. The works of Boomer and Bo Rangert certainly have been really outstanding with regard to laying a science foundation for that concept of even really as few as 4 implants. I was very skeptical, to be honest, for a number of years, how 4 implants could literally hold 12 teeth and work.
Upper and lower.
Upper and lower, correct. The so-called all-on-4, none-on-3 was not, was pretty, in fact, is still kind of a phrase that a number of folks use to say, well, I don't believe in that, I don't think it works.
And explain the all-on-4, none-on-3. All-on-4,
Well, all-on-4
none-on-3
meaning
means you had 4 in there connected with the bar,
Right,
it'll
lose one-
work,
lose
but
one
you lose
implant.
one implant and you
Right.
lose the whole case.
And potentially the case is gone. Well, it's not quite that way. Yes, in fact, one implant can fail or not integrate, but the reality is there's always a contingency plan. And in fact, in the maxilla, I rarely place 4 implants only for our full arch immediate load cases. I typically will place 5, sometimes 6, depending on factors such as pair function, the size of the patient. Typically, a male will be, have a harder bite, so to speak, biting with greater forces than a female, etc. But the bottom line is, yes, as few as 4 implants can work. The science is there. What we've been able to see over the years now is that even the concept of tilting an implant, to me, was unorthodox. 17,000 implants, axial placed only, all over my years. All of a sudden, I'm going to tilt these. Got to be out of my mind. Well, long and short of it is, like anything else, have to do homework, and went with a restorative colleague of mine to see Palomelo in Lisbon, Portugal, and the trek began there and continued visiting different offices of colleagues of mine who've been working with Laude on 4, et cetera, et cetera. And here it is, how many years later, where I feel now that I'm very comfortable, by the way, with the concept, absolutely, because it's based on primary stability, meaning basilar bone is huge to engage with these implants. And, of course, the concept of, as we talked earlier about, splinting. That is huge. Those two concepts alone allow, with appropriate occlusal concepts, allow for very predictable placement of these implants with teeth so patients can go home that same day. Now, that said, what, in fact, my lecture this afternoon here shortly will be on guided full arch reconstruction, but from a fully guided perspective, meaning we can virtually plan the entire case and not just at the time of surgery convert, say, a denture to a hybrid prosthesis. It's still a denture, and teeth can pop off, and there can be issues. And the way I see it, a patient is paying me more or less for a real nice Mercedes, and for 4 months they're walking around with a used 1987 Chevy. Not so good, I think. So, and not to say that that's a bad concept. No, absolutely. In fact, virtually everybody in the world is doing it that way, converting a denture.
Did you say used 1987? Because that's the year I graduated from dental school.
Oh, okay. Well,
that's how used it.
No disrespect to you, of course. But the way I see it now, with guided, meaning not just guided for placement of the implants, but in guided allowing for prefabrication of, now think about this, not a denture. This is a hybrid prosthesis. This is a PMMA, bar-supported, monolithic hybrid prosthesis that looks drop-dead gorgeous at time of placement. So when these patients look at this and they go home with this, they're very excited, as they should be. And being monolithic, teeth aren't popping off, they're not chipping off. So it's a very neat concept. And N-Sequence is the lab that I work with. It's
Sequence?
N-Sequence.
N-Sequence?
Yeah, the letter N is in Nick, Sequence.
Yeah, and are they in Tampa? You're in Tampa.
No, I'm in Tampa. They are in Reno, Nevada. Daniel Lopp, LLOP, is the brain behind this concept. And we've collaborated for the past 7-8 years now, his lab and my team, such that we've been able to evolve the work now in such a predictable mode that literally an upper and lower case dentate patient, terminal dentition patient, we can extract their teeth, place the implants, and place these beautiful looking hybrid prostheses all within a matter of a half a day, 4 to 5 hours maximum. They come in at 7, they're out at noon. They're not packing a lunch and staying all day. And again, when they leave, they have a beautiful set of teeth for 4 to 5 months.
You know what you have to do? I'm gonna throw you under a bus live on camera. Is you got to photo document one of these cases A to Z and get it on Dental Town. We got 195,000 townies that would die to see it. I call stuff like what you just said as dental porn. And you know, these guys can watch. These guys are watching Dental Town Online CE on their 60-inch big screen with surround sound. I mean, that would be. I want to see that case.
Sure.
Well, and can you hook me up with the owner of that lab for a podcast?
Absolutely, I can do that.
I also want to go back. I try to listen for things that maybe there's some viewer out there that's not quite getting. You keep dropping the term basilar bone. Explain that too.
Basilar bone, meaning basically that's the bone that we have in our maxilla and mandible. Once the alveolar ridge has resorbed to a degree, alveolar bone meaning the bony housing that we typically place our implants in. If we just took your teeth out, for example, the bone that's residual around in the sockets, etc., is alveolar bone. Under that, at the base, literally at the base of the mandible, base of the maxilla, meaning in the area of the floor of the nose, the piriform rims, the floor of the sinus typically. This is basilar bone, which is the hardest, the most dense bone. It's lamellar bone.
Now, do some people call that skeletal bone?
Sometimes it's referred to as that, kind of a bit of a misnomer, I think.
It's a misnomer?
I think so. Basilar is more descriptive,
Okay.
and therefore the goal, and it's a paradigm shift. It was for me to be able to place implants that are tilted, meaning the concept really was predicated from the get-go by Palomelo, Bo-Rangert, etc., on the fact that to get primary stability, even in a short area of bone, small amount of bone, as long as one can penetrate remote areas of bone, i.e. basilar bone, therefore implants have to be longer, 18, 20 millimeters or so, and even go transsinus, for example, from beginning, say, at the first, second bi area, typically, sometimes first molar if we can, and transcend the sinus and get and engage basilar bone at the base of the nose. Well, that's perfect, because those insertion torques then are, again, at minimum 35, typically much higher, 50, 60, 70 Newton centimeters, which means, and by the way, the baseline is 35. That's what's pretty much accepted in the literature now, meaning each implant, if you're placing 4, has 35 Newton centimeters of insertion torque, quote unquote, it's safe to load those implants. But the long and short of it is, it created a paradigm shift for me, because I never even thought about placing a tilted implant. Off-angled loads, pathologic, etc. Well, there's a magic, if you will, of splinting these implants. And that's really at the bottom line to all of this. Splinting allows for immediate provisionalization, and then ultimately integration of these implants. And at the 4th to 5th month mark typically is when we now convert that same patient to a full arch of, let's say, zirconium, which is absolutely gorgeous. And typically we place a full arch zirconium prosthesis in the maxilla.
What brand name of zirconium are you using?
Well, there's so many different types. There isn't a particular brand. The Zircon Zon seems to be the most widely talked about, because it was, I believe, the first one introduced here in the States from Italy. But there are certainly, the Preto Bridge is it's termed, but there are variations on the theme, so to speak. But the fact that it's such a hard material is a good and a bad thing. And I say good in that it's fabulous. It doesn't typically fracture that we're aware of, at least so far, the cases we've done now 4 or 5 years out. However, my concern, and this is a simple surgical brain looking at this now, is I am hesitant to place a full arch zirconium hybrid in a maxilla and mandible, same patient, because you've got two extremely strong materials against each other. Number one, just that click, click, clacking of noise is not so great. But secondly, these are two materials that aren't going to give. So
Right.
it's something in the system has to be a weak link, and that's going to be the implant bone interface. So my concern is that long term we may be looking at problems by having two arches of zirconium. Now that's a simplistic way of looking at it, but so in essence what I'm saying is what we like to do is in a two-jaw case, zirconium upper is the bridge, is final bridge, yes. Keep the lower provisional even for another couple months once the upper is done, allowing that patient to almost adjust and find their own centric, if you will, and their own comfortable bite, so to speak, and then do an acrylic wrap in the mandible so that we have a wear fatigue factor built into the system such that what's going to wear will be just the lower arch prosthesis. And that can be changed out certainly over time. And as I tell all our patients, with all of our implant work, the prosthetics is like a tire on a car. It's going to wear. It's not forever. The implants, yes, they should be indefinite. I don't say forever, depending on the age of the patient, but for all intents and purposes, our failure rate is so low now with so many different systems we work with that for all intents and purposes, it's safe to tell a patient what I just shared with you.
When older people ask me how long implants will last, I always say, the best thing about old age is it doesn't last that long. So don't worry about it.
Well, here's just a quick aside, as a comic sidebar, if you will. I tell the patient, of all the things that you possess, the only thing you can take with you when you do die or the implants?
You know, the aliens are going to be confused because they're going to come back a million years from now, and they're going to open up all these caskets. And the only thing there's going to be is these little titanium wedges and these 2 silicone packages. And they're like the breast implants and teeth implants are the only thing that they're going to find. I want to back up all the way to the beginning.
Sure.
So all the way to the beginning, here's an issue. A lot of the people that are losing all their teeth and need implants, it's because they're smokers and or have gum disease. And so I want you to first talk about this dentist out there driving to work right now, and he's got these patients, but he might be thinking, well, this person is or is not a candidate because of their smoking history. And it's easy for non-smokers to say, oh, well, I'll just tell him to quit smoking for a month and get him and he'll be good. But a lot of them aren't going to comply with that. And then number 2, we keep reading articles that, if you have a full mouth of gum disease and you pull the teeth, well, the gums heal up beautiful. But when you do place implants in the mouths of people who lost their teeth from gum disease, they do have a little, it can't be a true gum disease because the tooth is gone. When you don't have the tooth and the cementum and the plaque and the tartar, and now it's titanium, it's a totally different disease process. But can you talk about those 2 things, smokers and gum disease?
Sure. I think that's, as a matter of fact, that's a great question for lots of reasons, not the least of which is these are the 2 most prevalent problems that we see today. A lot of smoker patients, certainly in our country and throughout the world for that matter. And if we add the diabetic element to that, then that's a real nasty 1-2 factor of risk factors, if you will, that compromise anything we do, whether it's grafting, bone, tissue, or implant placement. Now, that said,
What percent of your patients are a smoker
smokers?
Or diabetic or both?
Well, the diabetic population is increasing for sure for all of us, as we see. Unfortunately, type 2 diabetics are very common. Obesity is a huge issue, as you know, in our country. 2/3 of what all adults are overweight or obese, basically. Obese being defined as a specific amount of pounds above normal weight, et cetera, et cetera. So diabetes, we're seeing more of it. Percent-wise, I would say probably, maybe hard to pinpoint an exact number, but it's on the increase. It's got to be at least a 10-15% element somewhere in there. Now, the smoker population is there as well. My rule of thumb is up to a pack a day, I will graft, bone, tissue, et cetera. Beyond that pack a day, meaning if I can smell smoke on their person, then I know they're not being upfront with me. I can't find it in me to graft, even if they're a controlled diabetic. A controlled diabetic, less than a pack a day smoker, that's a pretty good risk factor. But if they're smoking beyond that pack, and there is some science, but it's a little tenuous to support what I'm just told you, but that's been my rule of thumb for many, many years in my practice, meaning beyond that pack a day, I won't graft them. Now, implants, more lenient, up to even a couple packs. I've certainly placed implants in these folks, but that said, I qualify very clearly to all of my patients and tell them that, listen, our typical high 90 percentile success rate over so many years, 30 plus years now, really is compromised by at least 10 to 15% over time, meaning you're not in that high number. Marginal bone loss, the literature is replete with articles to support the evidence regarding bone loss with our smoker population.
And explain that to the listener. That's because is it the nicotine constricting the
it's a combination of things.
The blood, or is it the carbon monoxide?
Everything, yeah, all the above. It's a double, triple-edged sword. It's the smoke itself, the heat of the smoke in the mouth compromises tissue integrity. There's also the nicotine itself and the carbon monoxide that's formed that causes also a small vessel disease process, and that's really what hurts the most, is that the vascularity is compromised to all of the tissues of the mouth, and as a result, you'll get tissue breakdown over time that you would not normally see in a non-smoker, generally speaking.
And that's the same process as diabetes, right? The vascularity.
Correct. So that's why the 1-2 punch of a diabetic who smokes is absolutely at the highest risk, because they already have small vessel disease as a diabetic patient, and now add the smoking element, and you're basically choking off blood supply, which is at the heart of course, everything that we do, as you know, even though the mouth just happens to represent a phenomenal resource of vascularity for us to work with. It's a very forgiving environment, but I say forgiving when, quote unquote, there's no real pathology to speak of, i.e. the small vessel problem. So yes, the smoker, the diabetic combination is the most lethal one, and if in fact implants are going to be placed in these individuals, they need to be explained that without question they can be looking at some issues.
So in a case like that, I mean, would you just stream implant some extra spare tires there? I mean, if you were going to do a case on 4, would you just put in 6? Just
typically, not such a bad way to go. Yes, there's some ways, some strategies to work with these types of folks and to plan for them. One being, yes, in general, more implants is one way to look at it. Another is to use bioactive modifiers that I've used for more than 20 years now, from PRP to these are bloodborne bioactive modifiers, PRP, PRGF, more recently in the last 2 years, PRF.
Okay, can you explain all those terms for viewers?
Sure. These are just acronyms for bloodborne bioactive modifiers, meaning we draw blood and spin down the blood in different types of centrifuges, and the product that we get from that is one that is based on the technology and the concept of which particular one you're working with is predicated on either numbers of platelets, as in PRP, or the plasma itself with growth factors within it, i.e. plasma-rich in growth factors, and then PRF. PRF is platelet-rich fibrin. This is a growth factor, I say bioactive modifier rather, that is a second generation. In my opinion now, as I've seen the literature and the science behind this, which is why I've been using it now exclusively for the past 2 years as a modifier. It's a second generation bloodborne bioactive modifier because it now is such, rather I should say, it creates a fibrin clot that has growth factors that actually are slowly released over time, 7 to 10, 11 days out. These cytokines get released, and what they do is they accelerate tissue wound healing. So, for example, in a smoker, how important is it to be able to get primary closure and have that watertight as quickly as we can to prevent that smoke, because they're going to smoke that same day. We tell them don't smoke the day before, the day of, the day after, and pray that they don't smoke the day of. Well, typically they're going to light up pretty soon. The bottom line is with these bioactive modifiers, they upregulate a growth factor called VEGF, VEGF, vascular endothelial growth factor. And this growth factor accelerates soft tissue wound healing big time, such that within 15 minutes, you've got closure, you've got a seal because of using these growth factors. And by the way, very inexpensive, $12, $15 per blood draw, using test tubes, etc. Everything that's involved in the setup, very inexpensive, and should be used, in my opinion, with virtually every case that we do from a grafting perspective.
So what percent of your cases are you drawing blood and centrifuging?
All my graft cases. All of them, bone and soft tissue, and a number of implant cases, depending on exactly what I'm doing. Not necessarily a one-tooth case or a two-tooth case, but if I'm flapping bone and flapping tissue and exposing bone, typically I'm working with some bioactive modifiers.
And if there's a dentist out there listening to you right now, tell him how he could go down and see you do this in Tampa.
Well, the institute that I'm very proud to tell you that is now in its 25th year, the Pikos Institute in Tampa Bay area. We have been having courses now over all this time as a continuum, because my concept of how I look at this is that we all need to become hybrid surgeons. And by hybrid surgeon, I mean we need to have the ability to work with bone and soft tissue equally well from a reconstruction perspective, and of course place implants appropriately. So when we have all of that together, well, the restorative element really falls in place quite nicely because all of this is planned so well. But most importantly, the skill set of that surgical-based individual being able to do bone and tissue equally well, I think is absolutely over the top, because patients don't like to move from one office to another, as you know. And the trend today is under one roof doing virtually everything. And that's a European concept that's been going on for many years. And without question, the trend now in this country is as it is. And as you know better than I, more than, 125,000 or so restorative dentists in our country. Not everybody's going to be jumping on the bandwagon to do surgery, of course, but those that are doing it, my advice would be commit to it. Don't dabble. As Carl Misch talked about years ago, if you're going to commit to this thing, you need to. And in fact, quite honestly, virtually everything I do today, Howard, believe it or not, wasn't even remotely around in my residency in 1983 when I finished.
Ohio State?
Yeah, residency was Pittsburgh, University of Pittsburgh. College and dental school at Ohio State, and then at Pitt for Montefiore Hospital for my residency. Came down to Florida in 83, set up on my own, and fast forward 32 years later, I will tell you that I have averaged 130 hours of CE every year in my entire career. That's well over 4,500 hours of CE. And it's not just, sign in and take off to the beach. No, it's sign in, front row, tape recorder. I'm pretty obsessive. I love to learn. And it continues. And because of that, I've been able to continue to incorporate different concepts, different state-of-the-art technologies into my practice first, and then into my institute. So as a result, the institute it represents a continuum of bone and soft tissue grafting, as well as guided full arch immediate
so that's
reconstruction.
the Pikos, is how you said it.
Correct.
That's
Pikos.
Greek,
Yes,
right?
it is.
Pikosinstitute.com, Pikos Institute.com. And that area is a hotbed for stay-there people. People know that area. Clearwater, Florida is Bill Strop.
Absolutely, sure.
There
the
was
Dawson
the sinus
Center
lift guy, Dawson.
is just south of us, sure.
And Tatum.
Tatum, sure.
Is Tatum still down there?
No, actually, Hilt is in France, as I recall.
In France?
Yes, it's been there for a number of years now.
He moved to France?
Yes, near
Really?
Normandy. Mm-hmm.
Was that for love? Did he find a French woman and move there? Or?
To be honest, I'm not real sure. But,
not real sure, huh? Most people, they say you only leave your country for money or love. That's the only two reasons you left. So he must have found a French woman. I want to back up again about the diagnosis and treatment. We talked about smoking,
Sure.
periodontal disease. You talked a lot about the smoking, but let's go back to the periodontal disease. Is it fair to say, you can't have periodontal disease around an implant like you do a tooth? That's just two different beasts. But we do see that if you had periodontal disease and you place an implant, you're more likely to have like peri-implantitis. But what's the difference between peri-implantitis and periodontal disease?
Well, really, the two processes are very, very similar, believe it or not, Howard. In fact, unfortunately, a number of our patients think once they get an implant or implants that they've got this third set of teeth and they're immune to anything out there. They don't have to brush, floss, et cetera, et cetera. Of course, that's the worst way they can think. Without question, implants are vulnerable. They are. And in fact, the seal around an implant is different than around a tooth. What God gave us with a healthy tooth, that PDL, is a phenomenal element in that if a tooth is in trouble, in other words, if we hurt from a tooth, it's talking to us. The PDL's talking. It's maybe hyperocclusion, whatever the case may be. It's something that is reversible typically, but most importantly, we have a signal, a sign up front. Patient's hurting. We can address it and typically deal with it. Unfortunately, when an implant actually has pain associated with it, that's typically 99% of the time, it's history. It's a goner. So there is no precursor sign necessarily. A lot of this disease process is insidious, so bacteria basically can invade an implant more quickly, the interface between the implant and the bone, than with a tooth and the bone. So believe it or not, the implant is more vulnerable. So peri-implantitis is basically the analogous element to periodontal disease, more or less, periodontitis, if you will. The bacterial content has been shown in a dentate patient to be not that different, really, with an implant that's in trouble versus a tooth. And what I like to strive for, and I think many of our colleagues are in agreement. And again, as a surgeon, this is somewhat maybe radical to my own surgical colleagues, but the importance of attached tissue. For so many years now, I've been talking about. In fact, my soft tissue grafting course that deals only with implants is now in its 16th year, and it sprouted out of my bone grafting courses because I couldn't keep stuffing the soft tissue work into any of the bone courses. There wasn't any room. So the 3-day soft tissue course we do is devoted exclusively to implant-based surgical reconstruction, and the importance of what I stressed throughout that course of attached tissues everywhere, whether it's a single tooth case or a full arch case, grafting with either autogenous tissue, typically from the pellet, or much more commonly using an allograft like alloderm, which I've used in a vestibuloplasty concept for almost 19 years. The long and short of it is, I think the literature can support nicely that attached tissue really does minimize trauma around that implant, and therefore doesn't allow for that sulcus to increase any greater and allow for invasion of bacteria. So think about it. A smoker, a diabetic, is at risk because that attachment, which is really not an attachment as it is with a tooth, it's already compromised. Now, in a smoker, in a diabetic, etc., someone doesn't have good hygiene, these bacteria just have a blast. And they get in there and they do their thing, and there's the unhealthy red, erythematous, mean-looking tissue that we all have to deal with, etc.
Now, you wouldn't find any of those people in Tampa. Those are coming up from Clearwater.
Exactly right. They're totally out of my area. We're immune. We basically allow them to swish with ouzo, which is a fantastic,
great,
absolutely kills everything in sight.
I love
so
ouzo.
Yeah.
but go back. I'm going to pin you down. And go back and clear. What should a diagnosing general dentist be thinking if you got a patient with a mouthful of gum disease and you're going to pull those and go to implants? What should you be thinking from a diagnosing treatment? I mean,
well,
if you got a mouthful of gum disease,
first things first, what caused the problem is important. I mean, it's important to sit down with your patient, and as we've early on in my career, I would say I wasn't as nearly as sensitive to this as now, and over time, experience teaches you many things, but really looking at the patient as a true person, not just the mouth. We've said that from way back. Sounds great. Not everybody follows it necessarily, but the reality is getting to know the patient well enough, and specifically what happened. Why did those teeth, why were they compromised? In some cases, it's a genetic component. There's no question. You know that. We've seen folks in their 20s and 30s with rampant periodontal issues. Hygiene is great. They've been to dentists. It's not that they've ignored, etc. It's unfortunately a genetic element. Why does someone die from lung cancer and they never smoke? Things happen. We're programmed differently. Now, that said, that population aside, we've got the other issue, of course, just poor hygiene, the smoking patient, immunocompromised patients that have, my goodness, a number of these vascular collagen diseases, lupus, and you name it. They're so, scleroderma, on and on. So there are reasons that these teeth. How about Sjogren's? We unfortunately see a number of Sjogren's patients that, because their salivary flow is compromised, they have decay. So you start treating a couple, 3 teeth, root canals, crowns, and before you know it, the other arch is in trouble. And so many of these folks are so compromised that, yes, in fact, they may well, and they are, a number of them, good candidates for extraction and hybrid prostheses. Because then they can maintain hygiene so much better. But basically, in a nutshell, to answer your question specifically, these folks we need to know what happened first before we start edentulating. And by the way, even though I am surgically based, I wrote an editorial, at least 7-8 years ago in Implant Dentistry that specifically addressed, and I mean this with as sincere conviction as I can come across about this, and that is that this editorial was about our graduate programs throughout the country emphasizing implant work so much, and we're talking within oral surgery, within perio, within pros, within endo, virtually all of them. Pros, as I mentioned, meaning the emphasis is so much now for implant dentistry that saving teeth has become a lost art, and I truly am a proponent of absolutely saving teeth as much as we can, depending on the circumstances, certainly. But I'm not one to just jump in and take teeth out and slam dunk an implant home. I've done this too long now, and I've seen cases that I thought honestly from the year 1 or 2 wouldn't last 6 months, a year or two, even deciduous teeth maintaining their space over 20, 25 years. So as I've seen patients come back over time, I've had to eat a lot of crow and digest it, not so well, if you know what I'm saying. So tincture of time, you learn. The long and short of it is, without question, teeth can be saved even better today than ever before. So I would prefer that, the young dentists coming out of school can appreciate this, even though they may not have been taught this necessarily in their programs, and definitely in the specialty postgraduate programs. Really, all of our colleagues to keep a close eye on, the importance of saving teeth. Teeth are body parts. Nobody wants to lose body parts, really. And you've been around long enough, and you know that. Someone losing one tooth, and it could be the last tooth in their mouth, and they're freaking out over, oh my God, I'm losing that tooth, or 2 teeth left, whatever. It's a psychological, emotional element, etc. Certainly in those cases, that's a different story. But my point is, we can save teeth today. We really can. And root canal treatment, there's not a thing wrong with that. I think many of these teeth, even I thought resorption cases, etc., can be saved, yes. Now that said, too, not to sound hypocritical, it depends so much on the specifics of the case. But in general, I would just say that editorial that I wrote, I think, is real important to be able to put things in perspective. Yes, I'm surgically based. Yes, I'm passionate about what I do, but it's not, one size fits all. Not everybody walking into my office gets teeth taken out, even if they're sent for that reason.
But they always say in politics, if you want more of something, subsidize it. If you want less of something, tax it. I have to tell you, I don't really trust. I love the specialties. I don't really trust an endodontist or a periodontist who can't place an implant, because if your only tool is a hammer,
yes,
and everything looks like a nail, and you got to feed a family, you'll send a horrible failed root canal.
Sure.
And they'll just retreat it.
Sure.
But now I'm using endodontists to, if they look at that and say, well, I can make $1,500 either way. I can $1,500 retreat it. I can just pull that baby and put an implant. Same thing with periodontists. I really have a hard time trusting a periodontist who their only tool is flap surgery.
Sure.
I'd rather have a periodontist who says, you know what, this is going to be better. This would be better with a flap surgery, or no, this would be better, just remove it. But I want to go back to, we were talking about specialties, and you were talking about all these specialties teaching implants. Well, there's a new specialty, our 9th specialty now, oral and maxillofacial radiology. And you were talking at the beginning of this podcast that, when you got out, it was 2D X-ray, now it's 3D. To a dentist out there listening to the 3D X-ray machine, a CBCT is that's a 6-figure investment. That's $100,000. What system do you use at your Pikos Institute in Tampa? What software do you use? If they came to your institute, do you actually teach them how to use a CBCT? And then the even harder thing is, how do you learn to read a CBCT? Are you using software with your CBCT to help design and pick the length and width of implant? Can you talk about that?
Sure. Well, first things first, with regard to the oral maxillofacial radiology specialty group, these are really some very sharp individuals, and I have great respect for what they do, because quite honestly, any cone beam CT that we take, whether it's in our office, ourselves, or someone else is taking it, wherever, the long and short of it is, we are responsible, as is true for a Panorex radiograph, to not so much interpret, but be able to identify pathology on that entire field of view scan. So, not saying you have to identify and diagnose, but you at least have to know that there's something not right, and therefore refer the patient accordingly. Because incidental findings, my goodness, in any given day, our endodontists in our area love us, because periapical lesions for maxillary molars, 2 different endo studies in '08 showed clearly that 1/3 of all of these lesions go undiagnosed with a periapical radiograph, and that's been the standard of care forever. Certainly the periodontists swear by that, or have. So the long and short of it is, there is pathology to be noted, not just with teeth, but certainly in the sinuses, and if you're taking a full field of view, well, then you've got the skull, the vertebral column, etc. And of course, not everybody's going to be comfortable reading that. So therefore, my advice, loud and clear, for $85 or so, by all means, send these these scans to an oral maxillofacial radiologist, and these folks are well trained, and you don't want to send them to a medical based an MD, because basically they'll give you a very generic vanilla, no pathology noted, sinuses are clear, et cetera, whereas an oral maxillofacial radiologist will give you a detailed, typically 2-3 page report detailing maxilla, mandible, dentition, et cetera, et cetera.
And who are you using?
Typically, I'm using several different individuals. Cone beam, beam readers in Sacramento, California is one. Christos Angelopoulos is a maxillofacial radiologist here in New York. And Gail Reardon, who's in North Dakota, is an excellent person as well. All these folks have their own websites.
I don't want anybody pulling over their car or wrecking, trying to write down these notes. Could you, I put notes at the end of my podcast. Could you email me those
Absolutely.
Names so then they'll be in the notes section of the podcast?
I'd be happy to. So have someone else interpret, and therefore the monkey's off of your back immediately. If something is
that's
missed,
$85
on average.
And
correct.
so you do that through Dropbox, or
you can, and
how do you do
typically they have portals that you can input. You can literally upload immediately.
Explain the portal. You go to a website.
Yes, a website, and it just walks you right through it. It's very simple.
And what's the www on that website?
Well, Beam Readers is one. BEAM Readers, READERS, and then.
So what CBC did you go with? There's a guy out there listening thinking, okay, doc, name the one that you pick. You're a smart guy. What did you go with?
There's probably 40 units out there now, different
40?
brands. 40, yes.
Are you serious?
So it's a little confusing. From a cost standpoint, the good news is the cost has come down. So for about $85,000, one can get a very nice unit that has more limited fields of view. But I would recommend, especially if one is doing, work in both arches and 10-degree grafting, a full field of view machine is better. Typically, they're about a $125,000 range, $130,000.
Is there one that can do find a missing canal in a molar and do a full arch implant?
And full field of view, not to my knowledge right now.
So you'd have to.
It's one or the other.
Dentist, you'd have to either find one machine to find a missing canal or canal, or another machine.
Now the unit, the type I have worked with now for the past 4.5 years is the Carestream unit, formerly Kodak. I have the 9300 unit, which is the full field of view. Typically the endodontists in our area. In fact, thanks to me, they have all gotten I believe it's the 8100, which is limited field of view, but resolution is better, so therefore they can identify canals better. But the 9300 unit is the one that really, for me, gives me total access to everything I need to see. I had used for the first 5 years a different system, the iCat, which is nothing wrong with that unit. It's just that the software, in my opinion, with the Carestream is better, and their innovative element is on a different level too. So I prefer their software as well.
Whose software?
Carestream.
So I got that one too.
Yes.
So you're using their hardware and their software?
Correct. Now, software just for screening purposes, because the importance to me, and by the way, all of my patients, all of them get scanned. Even for a one-tooth case, if a patient refuses a scan, it's real simple. I refuse treatment. I mean, I'm to that point and have been for years. And I say I'm that dogmatic because, quite honestly, I can show you, Howard, a number of single tooth cases where there's pathology that's completely undiagnosed right in the area of the implant, division A bone. A 10-year-old could drill a hole and place a little screw in there and go home and Johnny's happy. But the reality is Johnny just put the implant into a periapical lesion that was completely undiagnosed with a PA, et cetera. So, and even a panorec. So I'm very dogmatic on, our folks getting scanned. The amount of radiation from one of these scans is minimal. I mean, flying from, cross country from, say, New York to LA, you got more radiation at 34,000 feet than one of our cone beam scans. Be out in Florida, 2 hours in the sun, same thing. So that argument gets squashed, pretty quickly. But I'm a big proponent of that. So scanning is important, absolutely, and being able to take that patient right from the get-go all the way through with virtual software use. And by the way, we use Simplant for a number of years.
Simplant?
Simplant, yes, been around for quite some time. It's a very nice diagnostic, as well as software, software that can be used for implant planning.
Where are they out of?
Simplant is basically out of Baltimore, Maryland. They used to be. Now I believe everything has been moved to Boston since Dentsply has completely bought out the company from Belgium. So they're now based in Boston. Now the proprietary software I work with for my full arch reconstruction is Maven Pro, M-A-V-E-N, Maven Pro, and that's proprietary to N-Sequence, and they provide that software.
You know what I wish you would do? I wish you would, I wish CareStream would put up some hour online courses on Dental Town showing, demoing their software. I think it'd be good marketing for them.
I agree.
Then, do you have contacts up there that?
I do. I can certainly talk with them and see if they can.
They came to my office about a year ago, and I told them to do that, and They provide that after you buy the system.
Sure.
Then you can go to their website and enter your code, and it's like, well,
they should have some up front. I would
that
agree.
Should be. You should put that ahead of free.
Now we did have a CT diagnosis.
By the way, I'm gonna be hitting you up every day for the rest of your life. I know you have some of the most, not only some of the most amazing cases, but long-term cases. 10-year follow-ups. So
I do.
How could we get you to put some online courses up on Dental Town?
I will do that. I do pride myself in follow-up. In fact, I've got 20, 25-year follow-up cases with good histology from grafting, for example, sinuses, etc., that I pride myself in, because it's not easy as a private clinician to follow these cases and to document them. But I've got a great staff, tremendous staff, been blessed with some terrific people. I have 4 full-time employees just with my institute, separate from my practice, but combining the two forces, we're really very fortunate to have some talented individuals to help me, without question.
Well, I know you're a legend before, and I know you don't need me or Dental Town or whatever, but I swear, I think if you put up, I think the more and more courses you put up on Dental Town, you're going to have standing room only in that institute of yours. Well, or you'll be able to raise the price, because if you go to market and you sell something and you sell it all the courses, then you raise the price.
Well, thank you for your kind words. It's been fun. I've thoroughly enjoyed my time in this field, and the R word isn't in the vocabulary. I love this work so much that I can see slowing things down, but walking away, I can't imagine what I would do 24/7. I've got my avocations of fishing and what have you, but this work is just so much fun, and the technology continues to change so nicely. And in fact, the half-life, quite honestly, of what we do today, as I tell all of my course attendees, other than anatomy and the things that I call base knowledge work material, that's not going to change. But apart from that, everything else has a half-life of less than 3 years, which means folks taking any of my courses, for that matter, within 3 years' time, 50% of it's obsolete. That's a scary thing to even, grapple with in your mind. So, it's tough for everybody to keep up. It's tough for me, and it's all I do. So therefore, I am excited about what I'm able to do in terms of packaging the different grafting procedures that I've done over the years.
So go through the Pikos Institute. How many different courses do you have? Can you go through the curriculum of the Pikos Institute?
Sure, be happy to. Basically, again, this hybrid surgeon concept evolves around starting with soft tissue. In order to do bone grafting well, it is imperative that one know how to do soft tissue grafting and soft tissue management exceptionally well.
But is your curriculum like intro? I mean, level 1, level 2, level 3, or
it is in a sense, yes.
Where would a listener start with?
It's a lot like John Coyce's program, where because I had asked John, I'm his scientific advisor, by the way, on implants, and I had asked John, where does one start? The answer is pick a place. No matter where you start, you're gonna not have everything you need to know for that course, but you got to start somewhere. So that said, soft tissue grafting is what I recommend initially for clinicians coming to us with base knowledge. That's a 3-day course. And all of our courses are live surgery, hands-on, which is typically pig jaws, and related items that we work with. So it's a very comprehensive approach in lecture discussion, of course. In other words, I see it as 4 ways for education to be effective. The one being a good PowerPoint, high definition video scenario. So they see it, they see the lecture material, the PowerPoint, they see the videos, then they do hands-on, and they see live surgery. That's all 4. At the end of that session, I'm not saying everyone can just jump, go home, do everything we show them. It's like an a la carte thing. You pick what you're comfortable with doing, et cetera, et cetera. That's soft tissue. Then we have 2-day modules of bone grafting. The 2 days of alveolar ridge augmentation base level, meaning extraction site management, non-aesthetic zone, and then ridge augmentation to include ridge splitting, mesh reconstruction, and even autogenous block grafts. Believe it or not, after all these years, still there's a place for it, and the concepts apply for so many other ways of augmenting ridges. The next 2-day bone graft course is sinus grafting exclusively, and that really is an exciting one for me because I've got now over 1,100 sinus grafts at 25 years, and the documentation, the way I do things in terms of just addressing complications, a whole 4-hour chunk of time is devoted to complications. Nowhere that I'm aware of is that ever shown as comprehensively. So that's 2 days of sinus grafting. Again, live surgery, hands-on, etc. And then 2 days of what we call complex bone grafting, which is 3-dimensional grafting using titanium mesh and titanium reinforced PTFE membranes for particulate grafting, including growth factors, of course, like BMP, etc. So it just so happens in November, which we typically do once a year, we're going to probably start this twice a year next year because it's so popular, is have all 3 courses back to back to back. Because we have a number of clinicians that come from overseas or from the opposite coast that want to come and spend not just 2 days, but at least 4, if not 6. So it's an a la carte. You can take the 2, or 4, or all 6 days.
And tell them how much that cost.
I'm going to say if you took all 3, I believe that is $9,800, I believe, for all 3 bone-to-bone, all 6 days of what we'll call total bone immersion.
So $10,000. So that if they went back to their office and placed 6 implants, that's a break.
Oh gosh, yeah. The ROI is out over the top. Yeah, the pearls.
Your first all-on 4.
The pearl. Well, no, all-on 4 isn't taught there. Now the other course.
I don't mean all-on for the brand. I just mean
sure.
4 implants.
Yeah, absolutely.
And,
absolutely. But no, the pearls that we share throughout all of the courses. And by the way, a number of courses, and this is no disrespect to anybody, but I consider them carpentry courses, meaning, I can teach you, if you were a secretary, typing only, et cetera, whatever, how to place an implant. You know that. Even a sinus graft, I could show you a 12-year-old. But the reality is, what's the why? The why behind it. I've got to show you science. I've got to show you documentation of cases. I've got to show you protocols predicated on reasons that have been well thought out, evidence-based, etc., and complications big time, because you're only as good as the complication you can handle for whatever you're doing, and you know that. So with all due respect to many courses, they're carpentry, even cadaver. I mean, you got to learn anatomy, sure, and that's a great place for it, but they become carpentry, if nothing, for lack of a better term.
I hope to see some online course of Dental Town. I really think that'd be a win-win. It'd be amazing for Dental Town, and I think it'd be amazing for Institute. We're out of time. We're past an hour. It has been a supreme, amazing honor to be lecturing on the same stage as you at the MegaGen Symposium and to be sitting next to you.
I look forward to that. It's been a pleasure. Thank you so much for your time, Howard. I appreciate this wonderful time together.
All right. Thank you very much. Hey, go to www.howardfarran.com and get a copy of my new book, Uncomplicate Business. I went through every monthly column I had written from 1994 to 2015, and I looked at those columns and realized that in business, you only manage 3 things: people, time, and money. So I stripped out all the dental and wrote a book that could take any business to the next level. I don't care if you're a dairy farmer, own a restaurant, you're a plumber. This book is for you. Pre-order my book now. Get your copy at howardfarran.com.